the graduates and all of the things that you have accomplished. Um, so when I graduated from pharmacy school in 1991, I had a BS in pharmacy, and I practiced as a pharmacist for many years. And we were taught about, as a BS pharmacist, we were taught about the chemistry and the pharmacology and all that stuff. But when you go out into practice, you see the medicines don't always work for everyone. And some people have some pretty bad side effects from it. But at the time, we didn't really understand why. Several years later, I went back for my Doctor of Pharmacy degree. And in 2017, I had a class in pharmacogenomics. And that really opened my eyes to this whole science and the usefulness of it. And so I went on and I got further study. I did further study in the field. And so that's what I'm going to talk about a bit today. So I want to start off with the science behind the pharmacogenomics, and then we'll talk about case studies. And then as we go on, we'll get into some of these other topics. So the first topic is precision medicine, which is using the individual's genetic makeup or DNA to deliver the right treatment at the right time, every time to the right person. A quote from President Barack Obama back in 2015 when he was president. Other terms, pharmacogenetics is a study of how variations of a specific gene affect the way a person responds to a particular medicine. And then pharmacogenomics is looking at the entire genetic profile or more than one gene to look at how the person will respond to medications. Pharmacogenetics and pharmacogenomics a lot of times are used kind of interchangeably, but that's kind of the way the more appropriate term if you're looking just at one gene is to speak of pharmacogenetics, and if you're looking at more than one, to look at pharmacogenomics. So this picture is just a really good slide to demonstrate population differences. So for this group of people, for the little green ones, the medication is safe and effective. For the poor little blue ones, it's safe, but it doesn't do anything. And the little red ones, it isn't safe or effective. And then the orange ones, it works, but it's not safe. And so that's kind of where pharmacogenomics comes in to figure out which little group of people you belong to. So sometimes people have different versions of the same gene. And you can see on the slide, or maybe you can't. I'm not sure how big it is for you there. But there's a T here, and then and that changed to a C in number 2 and a C in number 3. And there's an A here, which changed to a G in number 2 and number 3. And then a G, stayed a G with this one and changed to a T. So these were 3 different versions of the same gene that different people might have. And having these different small changes causes the protein to come out a different way, or it may make you make more of it or less of it. So when you have just one little change like that, it's called a single nucleotide polymorphism, or SNP. And so the example here from the previous slide was CCGA coming to be CTGA. There is another type of problem that can happen, which is an insertion or a deletion, and those are called indels, where one or more of the nucleotides are accidentally added or removed from the DNA. So that would be where TTAC might become TTC or TTAAC. And again, these are going to change what the protein looks like because these cause the protein to be folded differently. Let me put my camera on so you can maybe see me a little bit. Let's see here. Okay, so there I am. You can see me now. All right. So depending on how the protein is folded, some people are going to have more activity and some are going to have less activity. And people with more activity, they label ultra rapid metabolizers. People normal activity are either normal or rapid, depending on how far back the references are you're looking at. And then decreased activity are poor metabolizers. If you have one normal one and one decreased activity one, you would be intermediate. So we can see there's a significant number of people who do not metabolize drugs normally, and you can look at this and see 99% of people are not normal. So it just goes to show you that we're all different and there is no real normal involved. So there are various types of proteins that affect medication effects, how the medication effects happen in the body. One is enzymes that can break down or metabolize the medications. Another one is a protein that can transport it into or out of the cell. And then we have immune system proteins that react to certain medications and cause severe reactions. And there are still things being discovered. This is really a fairly new field. This is a slide that shows right now enzymes involved in drug metabolism. Like I said, there are still these little others categories are things that maybe are still being discovered. There's a lot of that is not known yet. This is a list from 2015 of various gene drug pairs. And I'm not going to go through it with you just because it's a busy slide. I just wanted to demonstrate it. But I do want to click this link to genes and drugs from CPIC. So hopefully that will come up here for us in a minute. So this is cpic.org, and these are genes and drugs. And I just want to scroll through for you. This is the current list of medication and genes that interact and have guidelines. And when I started learning about this field, there were 35 of them. You can see now as I scroll through, it goes way past that. We have now, for guidelines, there are, we're still going. 315. And so in another month or 2 months or maybe more, it changes all the time. So go back to this. But that's a website, cpic.org is a website where you can go if you're interested in doing pharmacogenomics. You can look at the things that are known and that are suggested as far as therapeutic changes and so on. So to go into a little bit more about how the differences work. When the drug itself is active, if a person is a slow metabolizer, basically that means that they're not breaking down the drug as quickly. So you have a lot more built up in your blood, and so you are more prone to side effects. So we have a picture of half a tablet here because these people may need a lower dose. An intermediate metabolizer, you're still not breaking it down as fast as normal, but you are doing it faster than the slow one. So you might need a little different dose. Normal, you would use the usual dose. And then an ultra rapid metabolizer breaks it down really fast. So you don't have any in your bloodstream. So you need a higher dose. The opposite is true for drugs that have to be converted to that active form. So some things are not active until they're converted to something else. So when that happens, if you're a slow metabolizer, it takes a lot longer for the drug to become active in your system. And you might need a higher dose because you're slower at metabolizing it, at bringing it out into the bloodstream. From intermediate, again, you may need more than normal. Normal metabolizers are going to need the normal dose. And then if you're a really fast metabolizer, actually what you're doing is you're converting it really, really fast. So you have a whole lot of it in your bloodstream. So you actually may need a lower dose. So depending on which way it goes, which type of drug you have and where you fall on the spectrum, it can really change the amount of a medication that is really the optimal dose for you. And now I'd like to go into a little bit more about specific examples. So CYP2C19 affects multiple medications, and this is one that is most frequently, we use it for clopidogrel, but it's really used often for psych medications and various other ones, and we'll talk a little bit more about those later too. But this is a slide that shows the metabolism of clopidogrel. And we see here it's an inactive compound. It has to be metabolized twice to get to the active metabolite. And in both steps, CYP2C19 is an important factor. We also have pasigrel, which also has to be metabolized to an active product. And then ticagrelor, the parent compound, is actually active, so it does not require the metabolism. So for somebody who is getting put on, who needs to have one of these types of drugs, you would say, well, why don't you just give everybody the ticagrelor then? Well, here, at least in the US, that medication is very expensive. And so the clopidogrel is actually the least expensive, so we want to use it as often as we can. But if you're an ultra metabolizer, that is okay. You would still use the labeled recommendation or a normal metabolizer. But once you get down to having at least even intermediate or a poor metabolizer, you're not metabolizing it into its active compound. It's not doing anything for you. So at that point, it's important to change to something else. And those would be people that might do better with the ticagrelor. These are some other medications also affected by this particular CYP2C19. And you can see it can go either from an active one to an inactive, or from an inactive one to more active. And you can see all different types of medicines are involved. So looking at sertraline, for example, if a patient is an ultra rapid metabolizer of that one, you would go ahead and start with the standard dose. Or the extended metabolizer, you would start with the standard dose. An intermediate one, you would still start with the recommended dose. Now, if you happen to be a poor metabolizer, though, you might want to reduce the dose because you're more likely to have side effects. And if you're an ultra rapid metabolizer, even though you're starting with a regular dose, you need to be prepared to bump it up a bit, because it may not be as effective for you. CYP2D6 is another very common one. These are some examples here of various medications that would be affected by that particular enzyme. And this is one that I'd like to talk about with the opiates. Codeine is a good example. It's not effective by itself. It has to be metabolized to morphine to become effective. And it's metabolized to morphine with CYP2D6. Hydrocodone needs to be metabolized to hydromorphone. It has a little activity on its own, but not near as much as hydromorphone once it's metabolized there. And the oxycodone can be metabolized to oxymorphone. So this is a fairly important enzyme when working with the opiate medications. So for poor metabolizers, the codeine has no effect. But the problem comes if you have an ultra rapid metabolizer. It changes so fast to morphine that people are at increased risk for respiratory depression or accidental death. And that's something we ran into in the US. They used to give Tylenol with codeine to new mothers. And so because they thought it would be a more mild sedative and it wouldn't affect the baby so much. And for most people, that was true. But for those people that had the ultra rapid metabolism, they changed it all into morphine so fast that the babies would have a morphine overdose and they would go into respiratory depression and die, and people wouldn't know. So they quit doing that. And in fact, we don't even use Tylenol with codeine nowadays anymore for anybody that's pediatric. So again, we can go to the CPIC guidelines and look at the guidelines for preventing adverse drug effects. They have another set of guidelines there. Now, moving into another type of protein, the SLCO1B1 is the one that does the transporting of the statins into the liver cells. The statins are not effective until they're brought into the liver. And so once the gene is altered, the protein is altered and taken up on those. If it keeps the statin from being taken up, then you lose your effectiveness of that statin, and it's just circulating around in your system. When it's circulating around in your system, that's when you start to have those muscle problems that people tend to have with the statins. So simvastatin is affected the most, but atorvastatin is even affected, and some others are also affected. And then the last category I want to discuss is the HLA, human leukocyte antigens. And these are there on almost all human cells in the body. And what they do is they present peptides to the immune cells to cause them to have an immune response. And so they're very critical for normal immune function and help with pathogen recognition and so on. But they also tend to respond badly to certain medications. So if you happen to have a positive for one of these particular tests, these can cause Stevens-Johnson syndrome or toxic epidermal necrolysis, both of which can be fatal to people, very, very bad skin reactions. And so if you have these as positives, you want to avoid these medications. If you have this one positive with a Bacavir, for example, it is more likely to cause anaphylaxis, which is also a pretty bad and possibly deadly scenario. So this is another kind of test that's typically done. A lot of times these particular ones are more common especially this one is more common in patients of Chinese descent, but you can find them various other places as well. Just because you are not from China doesn't mean you don't have one. So one dose doesn't really fit all. The pharmacogenomics can really help patients get the right dose of medicine faster, so you don't have to try so many medications before you find one that works. And it also helps you avoid adverse effects. What it does not do is it does not tell you specifically this one is going to work for you. We don't know it'll work. We just know it won't work on these. So we have some case studies to talk about. And the first one is outpatient pharmacy. So this is based on a patient that I had. A 60-year-old female came to the pharmacy to refill her antidepressant, and she had been taking paroxetine 40 milligram by mouth daily, but it didn't seem to help her. And she had taken it in the past for a few years. It didn't work for her, so she just stopped. And her symptoms are worse again. She feels like she needs something, so she started it again, but it still doesn't seem to do much. So she had heard about pharmacogenomic testing and wanted to see if it could help. And so we talked to her about pharmacogenomic testing, and she decided to go ahead and do it. So these are her results. And her CYP2C19, she's normal, CYP2C9, intermediate, CYP2D6, she's an ultra rapid metabolizer. And so for paroxetine, that means it's metabolized very quickly into an inactive compound. So we should recommend a different medication for her. So for this particular patient, our clinical recommendation then would be to stop the paroxetine and then choose some other antidepressant not metabolized by CYP2D6. Since she's a normal metabolizer of CYP2C19, citalopram would work for her. That's one that is metabolized by this one, but not that one. And so it would be a good choice. There are lots of other ones that could also be used. If you have a different preference or something, you can't get this one for some reason, we have lots of shortages around here. There are lots of other options, but that would be the one that would be one recommendation that can be used. Now, I currently am working in hospice pharmacy when I'm when I'm not working at the School of Pharmacy. So I decided to bring in an example from hospice. A 77-year-old male admitted to the hospice with a diagnosis of COPD, but he was in an automobile accident and he had broken bones and some bruising. They prescribed to him hydrocodone 10, acetaminophen 325, which would be the same as paracetamol. One tablet every 4 hours is needed for pain, and he has been taking it every 4 hours around the clock, but it hasn't been doing anything for him. He still rates his pain as 8 out of 10 on a pain scale of 1 to 10, with 1 is the least and 10 is the most pain. So before he came into the hospice, he had pharmacogenomic testing done. So he brought the results into us. And we see he has a CYP2D6 star 4 poor metabolizer. So remember back on the previous slide, the hydrocodone has to be converted to be more effective. So the hydromorphone and morphine do not require metabolism to the active ingredient. So either of those would be a good choice for this patient. We're going to stop this hydrocodone and we're going to change to hydromorphone 1 milligram and just take that every 6 hours, but then also add morphine liquid. We use a lot of that in our hospice, partly because it's easier for people who aren't able to swallow and things as much as they progress in their diseases. Also because it's very strong and it works for a lot of things. So we would give 10 milligrams by mouth every 4 hours as needed for breakthrough pain if he needs more than the hydromorphone. And then the third example would be from a hospital pharmacy. A 58-year-old female presenting to an emergency department with chest pain, diagnosed with a ST elevated MI or STEMI. And she went through heart cath and has been admitted for observation. New medications include aspirin every day, nitroglycerin is needed, atenolol once a day, atorvastatin once a day, and clopidogrel once a day. But because of the statin and the clopidogrel, they went ahead and ordered the pharmacogenomic cardiac panel because they want to make sure these medications will be effective for this patient. And the results came back. And it's a good thing we did for this patient because these medicines would not necessarily work for her. The CYP2C19, which again, this is our clopidogrel. We have a poor metabolizer, so we need to change the statin. We have a poor function on the one that would transport it into the liver cell, so we would need to change that one. And then the CYP3A4 is normal, and so that shows for something that would be metabolized by that, it would be okay. If we needed warfarin information, we've got that or these others, but we don't really need those for this particular patient. So our clinical recommendations for her would be to discontinue the clopidogrel and start ticagrelor 90 milligram by mouth twice a day. And then due to those other results, to either excuse me very much, on the atorvastatin, we should actually, I have incorrect information here, we should just change it to the rosuvastatin 20 by mouth daily. So that is the end of this particular part of the presentation. My references are cited on the slides. And then if you're interested more in learning more with pharmacogenomics, pharmgkb.org is a good website, or cpic.org is another really good website. They have all the gene drug pairs, the guidelines, and all of that information. And so at this time, I will say goodbye and pass it on to the next person. Thank you.
Thank you so much, Professor King. This area of pharmacogenomics and the way drugs, they will behave differently in people is a very big issue here. And I have some questions, but when I look at the list of presentations that you're going to make, You have 3 sessions of presentations, and I think the issue of the questions we are going to ask them after your last presentation, Professor. Otherwise, we have really appreciated your presentation, and you'll come back to present the part of applications in practice of pharmacogenomics. Otherwise, this time I will welcome.
I wanted to say, I went ahead because I may have done the wrong thing. I kind of combined the two into this one presentation, so that my presentations wouldn't be scattered so much. I was under the impression that I should be doing that. But I was expecting to come back and talk later about the ethics and some of those things.
Professor, it is okay. It is okay.
Okay.
You can do that.
Okay.
Yeah, you can do that.
Okay. Okay. Thank you. I'm sorry.
Okay, then our next presenter is our professor, Professor Oluka, Professor of Pharmacology and Pharmacognosy. Welcome, Professor. Thank you. And pharmacotherapeutics, yes. Thank you, Professor Gwatai. Yeah, let's clap for her.
Okay, so good afternoon. Yeah, as you've heard, my name is Margaret Oluka. I'm a professor of pharmacology. I work at the School of Pharmacy, and I'm going to present some work that we have been doing at the School of Pharmacy on pharmacogenomics that started with my PhD, going forward together with the students that I've had to supervise in this area. I'm glad that Professor Susan has already taken us through the background of pharmacogenomics. She has explained the science. So my task right now, I'm going to just give you a bit of how we have been trying to apply pharmacogenomics, or at least to get some work done so that it is not so abstract. As you may realize, you cannot see a gene with your eyes. A gene is just assumed. You assume the gene is there. What you see is the phenotype. The genotype is just, you just write there, as she was showing you, A, B, C, D makes a gene, okay? But now for you to see a gene, you have to have it expressed. And what is expressed is what you see. If you see a green eye, you know somebody has genes for green eye. Like now, because I'm tall and black and beautiful, you know I have the genes for being tall, yes. So that is what the genetic thing's all about. So today I'm going to present, good, so we are ready to start. Yeah, so the objectives of my presentation is essentially, as I've said, is just to give you an overview of the most common drug metabolizing genes that we use that are relevant to the most common drugs that we use in our setting. I realized as we read many books, or as I go to conferences, especially in the West, you find they give examples of drugs which we don't use here. So I always want to customize so that at least we know some of the common drugs that we use and which genes, drug metabolizing genes, account for them. So I'll do that. Then I will also give an overview of the metabolizing genes relevant to the African population. Then I will demonstrate variable distribution of this, what you hear, the variability, the genetic variants, which ones are they and how are they distributed between individuals and between populations, because that is also a major issue with pharmacogenomics. And then I'll highlight some research that we have done here at the School of Pharmacy. So the scope of pharmacogenomics really is that the drug response in any person at any time is affected by either genes that influence pharmacokinetics or genes that influence pharmacodynamics. For pharmacokinetics, these genes affect drug metabolism or drug transporters, the things that break medicines in the liver, and the genes, the proteins that carry medicines around the body and across cellular membranes. Then pharmacodynamics, as you all know, is about drug target proteins. So most of the work in pharmacogenomics revolve around this area. So this presentation is going to be on drug metabolism. So what I have now on the screen are the array of drug metabolizing enzymes in our liver, the whole lot of them. They are divided into phase 1 metabolizing enzymes and phase 2 metabolizing enzymes. Phase 1 are the ones that prepare the medicine. They put functional groups on the medicines, like hydroxyl group or a carboxylic group. Then the medicine moves to phase 2, where they are made more polar. And then after that, the body can get rid of them. As you remember from your pharmachem or pharmaceutics, when you make a medicine, for it to cross membranes, you make it lipophilic so that it can cross membranes. But once it has gone to the receptor, you have gotten your therapeutic response, the body needs to get rid of that medicine, and therefore the body needs to make it more hydrophilic so that it is removed from the body and terminates its effect. So that is the role of metabolism. So I'm going to now talk about drug metabolizing enzymes. I have selected some that are relevant to our practice here in Kenya and other African populations. So what I have right now on the board is a group of genes. They are the same ones that Professor Susan has been talking about. So it's cytochrome P450-19. It has two major variants, star 2 and star 3. Those stars are the variant. So a variant is another form of a gene that has slightly different activity as the normal one, okay? I don't know a good example that, on real life, but maybe if you have a chicken, and then that chicken, it gives birth to one which is not looking looks like it, but not exactly. You can say that chicken is a variant, okay? So the variant, it is, the variant is like the normal one, but it does not have the exact activities. So in cytochrome P450-19, you find that star 2 and star 3, they're actually called null alleles. They do not have the activity. And that is what Prof. Susan was talking about, that if you give a drug like clopidogrel, and which requires metabolism for it to act, it will not act. And if somebody has these variants, they will actually not have therapeutic effect. Then CYP2B6 also has a variant called star 6 and star 18. And the drugs which are in the middle of my, let me concentrate more on the drugs, because I think Prof. Susan has done a lot on the genes. So the drugs that are put for us here are the drugs that I know if you see them, you will recognize them. And our BFAM5, when you're going to the hospital, you will not miss to see omeprazole or esomeprazole. So I want to put these examples that we know. Nevirapine, efavirenz. Those ones are metabolized by CYP2B6. Then we have CYP2D6, a very important gene because it metabolizes almost 25% of the medicines we use and almost all classes of medicines, like CNS drugs, like Susan was showing you, paroxetine, the antidepressants, the antipsychotics, the cardiovascular drugs, all those are metabolized by this enzyme. And this enzyme is very, very polygenic, which means that it has many variants. The ones I'll put there, star 4, star 5, star 10, and 17, those I put them there because they are very particular for populations. So star 4 is mainly found in white people, Caucasians, and it is a non-active allele. Then star 5, it exists in all populations, and it is a deletion allele, so it is not there. If you have it, If it's the only one you have, then you can't metabolize medicines. Then star 10 is specific for Asian populations, while star 17 is specific for African populations. So I put them there so that we can at least be able to understand. And the medicines are put there like tamoxifen, anticonvulsant drugs, you know them, antiarrhythmics, and codeine. And codeine, Prof. Susan has already shown you, if you have a null allele for CYP2D6, like in our case, the star 17 is a reduced activity allele. So if a person has that allele and you give them codeine, they will not convert it to morphine, and they will continue screaming in pain. And you see, sometimes when nurses will say that now you are addicted to the drug, you are crying for pain, so that you be added the medicine. I've been a victim. And yet I may have the null allele, so I cannot convert codeine to morphine to give me pain relief. You see, so unless you have that insight, which is most of the times it's with the pharmacist, so then you can actually mislabel a patient, telling the patient that they are addicted, yet they are not addicted. Okay, then NAT2 is a very important enzyme because it is the one that metabolizes isoniazid, the first-line TB drug in this country. So in this slide here, I have the alleles, which I've already taken you through, but now in the second and the third column, I'm showing you the mutations. This is, I will not go through the mutations because Prof. Susan has already alluded to them. But the last column, I've also alluded to them, the effect that the mutation has on the enzyme. So when there's a mutation like that, the enzyme is either made non-functional or it is more functional, it becomes very active or not active or slightly active. So you get poor metabolizer, extensive metabolizer, and rapid metabolizers, and all those interfere with the outcome of therapy. So we move on to, so these genes that I'm showing here are very common, are relevant to the drugs that we use in this country. So now I'll take you through population pharmacogenetics concerning some of the work that we have done, as I was saying, to move us away from the abstract gene to show us the phenotypes. So we decided to undertake some studies to elucidate the distribution of these allelic variants genes in Kenyan populations and to compare how the distribution in Kenya compares with other African countries and also with Caucasian and Asian populations. So we selected CYP2B6 because that time it was HIV was very hot, and the medicines for HIV were new, they were not really known, and CYP2B6 became a very important enzyme to be characterized. Then CYP2C19, D6, NAT, and the last one there is glutathione. It is the enzyme that protects us from toxins, from drugs that are converted to very active metabolites that can attack your protein in the liver and give you cancer, for example. So it was important for us to characterize it as well. So we did a study in Kenyan populations. Our study, we sampled people from Central Province, the Bantu. We are looking for Bantus, and we know where they are, mainly in Central Province, for us to get them. Then we also sampled Nilotes from the Rift Valley, the Eastern Nilotes, and we sampled the Western Nilotes from around the Lake Victoria. The reasons why we are calling them, these populations, we are banding them together as Bantus, Nilotes, etc., is because African populations are actually classified in terms of ethno-linguistic orientation. So there are about 6 ethno-linguistic groups in the whole of Africa, and you can put all African populations in those groups. So that is why we are using that characterization. So we did our study together with our collaborators, and so we were working with Tanzanians, Zimbabweans, South Africans, and also Nigerians. So we finished this study and we published it in the European Journal of the Journal of Human Genetics. And this is what we found. Because this was the first study to elucidate the distribution of these different types of the same enzyme in Kenyan populations. So now we know that in Kenya we also have some STAR4. You can find some STAR4 allelic variant of CYP2D6 in Kenya. It is an inflow from the intermarriages. It was actually quite present in the Maasai, who had married with some Europeans. You know, the European ladies, they have a liking for okay, yeah. So so the red shows the Kenyan distribution. What I want you to do is compare Kenya with Tanzanians. You can see they are closely related, so our populations are not different in terms of the distribution of these enzymes. But if you look at that STAR4, the frequency in Kenyans is 1.7, but the frequency in Caucasians is about 20%. And in Asians is also very low. That is why it is called Caucasian-specific allele. Then you look at STAR17, the African-specific allele. It is not different from what we have in Tanzania, but you look at Caucasians, it is 2.1 or not even present in Asian populations. And then, so then we go to CYP219, CYP2C19, STAR2 is 16, same in Tanzanians it is 18, very high in Oriental populations, Asian populations. And then CYP2B6, the one that metabolizes the antiretroviral drugs, efavirenz and nevirapine, 35%, 39% in Tanzanian, and Caucasians 25 or 21 in Asians. So that is how it goes. So this data was very important at that time because it put us in the map so that we could also people can look up some of these frequencies in Kenyan populations. And they are not different amongst the African populations. We were measuring almost the same. How about the phenotype? How people, when you put the genes together, then you get the phenotypes. And the phenotype is either it is an extensive metabolizer, intermediate metabolizer, or a poor metabolizer. And again, we characterized for Kenyan populations, we compared with what we found for Tanzanians, also for Nigerians, also for South Africans, and also for Caucasians and Asians. So again, we found the trend was not different from the other African populations, and the published work in the European and the Asian population, we were able to validate with them. So after doing that study, we now had a good idea of the distribution of these drug metabolizing genes in Kenyan populations and how they compare with the other African populations and of course already published work in the European and Asian populations. So now I'll take you through some of the studies we have done to see whether these genes we are talking about have any clinical applications. Do they actually make any difference to patients using these drugs here in Kenya? Okay, because we have determined that the allelic variants are the same like the ones in Tanzania, very different from the ones they have in European populations, but how about their applications? So I'll take you through some of the studies we've done with Professor Guantai sitting there. So the ones that I'm going to present are these genes, CYP2B6, for efavirenz and nevirapine, we have done several studies. CYP2C19 we have done, and CYP2D6, and also for NAT2 for the metabolism of isoniazid. I will not present all the studies because there are so many and I was given a short time. So I'll try to see. So let me take you through HIV pharmacogenomics. So for HIV, I'm going to give you an insight about abacavir and hypersensitivity reaction. Professor Susan alluded to it. Then some work we have done on nevirapine, and also there's some work we have done in efavirenz, but I will not present that today, and also atazanavir. So the first study we did with myself, Prof. Okalebo and Prof. Guantai, together with our collaborators from the University of Washington, we characterized cytochrome P450, 516, on how it impacts on the levels of nevirapine of different women taking HIV drugs. These were from the coast. This cohort was in Mombasa, which was being followed by the University of Washington. So what we found, I will not take you through the methods. I'm just giving you an idea of what the clinical outcomes were. So we found that the gene actually affected the genotype, which I said you cannot see, but you can only imply. Now we could see what we were doing was to take blood levels of nevirapine after women has been using them and they had reached steady state levels. My friend here will understand steady state levels, Dr. Kimoto. So we waited for the women to take the nevirapine. Once they had reached steady state levels, we took blood from them, then we took to the lab. We determined the levels of nevirapine in their blood, and then we compared the people who have various genotypes of these genes, and then to see whether their activities that we know theoretically actually translate to what we should see in these women. And that we can confess from what we are seeing there. You have not reached there. There, so we are there. Yeah, so that is panel A. So what you can see is that it's out of range. So I'm so sorry, it's out of range. But what you see at the very end there, what you see there is the levels of nevirapine in people who have a normal functioning gene at the end. Then the one in the middle are the people who have a gene that is a bit slow. But the one at the very end are the women who had a very slow gene, the gene that was affected much more by mutation. So that gene was very different from the normal gene. And you can see that their blood levels for nevirapine were high. Remember, when you give a medicine to a patient, that's why we have the dosing intervals. You give after every, if it is 8 hours your BD, you want to give back, you want to give the next dose when the medicine level has come down, and you want to keep it up, and you want to make sure that the medicine is always at the same level above therapeutic index. Okay, so so what happened that now these ladies with this gene here, the blood level for nevirapine continue to be very high because they have the genotype that does not work normally because of mutation. So it is called poor metabolizer or slow metabolizer. So their blood levels are high. So that one we were able to prove that actually this cytochrome P450 B6, it actually has clinical implications in the drugs that it actually metabolizes from this experience. And another study that our colleagues also did on efavirenz, they were able to also prove that the same enzyme given to people taking efavirenz, the people with the slow gene were having more frequent CNS toxicity, very prominent CNS toxicity compared to the normal people who had the normal gene. So it has been proven, and actually there was a cry out that in African populations, the manufacturer was supposed to reduce the dose of efavirenz to make it 450 instead of 600. But that did not come to pass because they chose not to do the clinical trials again So you can see if you have patients on efavirenz, some people have actually up to now very severe CNS effects, and other people have normal, they don't worry, they don't feel anything. So people with the gene, with the slow activity, others people who have very severe CNS effects for nevirapine. So that is what we can prove. So the same thing with the 983, it's another mutation. It shows the same pattern, so I will not belabor the point. Yeah, so when we looked at the other parameters for these women, we looked at the CD4 levels, because CD4 levels is one of the indicators of whether a medicine is working or not. And also we found that the genes, the people who had high levels of nevirapine in their blood, they had better improvement on CD4 levels compared to those which had, the ones who had slow enzyme, they had higher nevirapine levels, and therefore their CD4 levels were recovered much faster than the ones which did not, the ones which were metabolizing the medicine too fast. Okay, so that was also, we were also able to characterize that. So in the other end, if you have higher blood levels, your CD4 recovers faster than the ones who had lower levels. But the difference was not so significant in such a manner that there would be any worries to change the dosage. So that was about that study on the impact of genetic polymorphism on HIV therapy, which we were able to prove that it had clinical implications. Then I want to take you through adverse reactions and how pharmacogenomic biomarkers can help us to deal with them. And then this is based on abacavir hypersensitivity reaction. Dr. Susan showed something. So abacavir, which we know is one of the medicines in the Kenya ART guidelines for children, it normally can provoke severe hypersensitivity reactions that can actually be life-threatening. And this hypersensitivity reaction is connected to that gene, the HLA gene. And this gene in white people, it occurs at about 5 to 8%, but in African populations, it's about 0.5 to 1%. So when we took abacavir to put in our Kenyan guidelines, this information was already known, but we do not test people to find out whether they have any of these mutations. But in Caucasian populations, it is a must that you must test. But here in Kenya, we can't afford, so we normally just give the medicines. So this case study, unfortunately, our colleague is not here. This is a study done by Professor Keegan, our own very pharmacist at Moi University. He presented this case report of severe abacavir hypersensitivity reaction that they came across in Eldoret MTRH. Because as far as we know, whether the gene is very rare, there'll be those people who will be affected, and this is one of the cases. So they had this case, it is described there, they just gave the case history. Apparently the patient suffered, but after a while they actually came to hospital when they were very sick, and then they were treated. Unfortunately, when they went home, they again took their abacavir and had to come back to hospital in a very, very severe state. So they were treated for actually 27 days. So before this, this is one of the few cases of abacavir hypersensitivity reactions. In fact, this is the only one I could find published. Okay, so I also discovered that our friends at Aga Khan University had also seen a case, and they had characterized the prevalence of this gene in Kenyan populations with HIV infection, which is an excellent work, because most of the times we don't have local data. Data we use only from other countries, like Black Americans are usually our index, because we don't normally have data from Black African in our countries. So our Aga Khan colleagues actually characterized this. And as you can see, the prevalence, looking at the red only, we don't have time to look at everything. The prevalence is about 0.8%. So they were able to demonstrate that it is true, it is a rare gene, but one can still be affected. So normally we don't actually test, because you would have to test so many people before you find one positive. So it is not cost effective to test. So that is how pharmacogenomics can be used to deal with adverse reactions. Then one of my students, today he's not here, I think he's online, Dr. Kagia. When he was my master's student, he characterized the membrane transporters. Remember, I told you that most of pharmacogenomics is either on pharmacokinetics or pharmacodynamics, and membrane transporters are the gates that allow medicines to pass through membranes from cell to cell. So there's a gene there that allow medicines to enter cells. Actually, it is stationed on the membrane of cells to throw out things not to enter the cell. Okay, like in the GIT, it sits there on the membrane called the enterocyte to remove things which you may eat, and God told you not to eat, so that they don't enter your body. Remember the book of, which book is it, Elizabeth? Where God gave the Israelites a lot of things to eat and told them, don't eat this. So sometimes, as human beings, there are things you are not supposed to eat because they are poisons. But when you eat them, this gene is actually on the membrane, on the GIT, and it's called an efflux pump. It pumps things out of the cell. So Dr. Kagia characterized this in Kenyan population, one of the few studies, and he was able to show the distribution of this in also HIV patients for the various alleles. So it is an excellent work. And he actually showed that CD4 levels were actually affected by this gene, because it was against, the patients were taking lopinavir, and this gene was pumping out, it is stationed there to pump out lopinavir. Okay, so people who had the mutation, the people who had the mutation are the people who are better off, because then they were able to keep more of the medicines in their blood. So now I'll take you through pharmacogenomics of cancer chemotherapy with an example of tamoxifen. So tamoxifen, as you may know from these students whom Professor Guantai has been teaching cancer chemotherapy, is that it is an adjuvant endocrine therapy for estrogen receptor positive breast cancer. So it's a very important medicine because when taken successfully, it reduces relapse from breast cancer. Now, this medicine is actually metabolized. It is a prodrug, meaning, as Prof. Susan told us, it is given in the form when it is not active. And in the body, we trust that God has put those enzymes in our livers, which we have characterized by genes, that the liver is there, it will be converted to endoxifen, which is the active metabolite. But unfortunately, one of the most important enzymes in our bodies that convert tamoxifen to endoxifen is very variable, and in some cases occurs as a non-functional alleles, like the STAR4 found in European countries, STAR10 found in Asian countries, which those ones are null alleles, they don't work. But here in Africa, in Kenya, we have the STAR17. Fortunately, God knows that we don't have a lot of money. So the STAR17, it is reduced activity allele. It is not completely inactive. It is inactive partially, okay? So it means that if somebody has double, the double STAR17 double, that is called homozygous, it actually becomes poor metabolizer. It means that when you give them tamoxifen, they will not get therapeutic effect, okay? And we have seen that some of the people actually are like that. They have star 17 double. You remember they normally have two. What do we have in the chromosomes? You have two layers, isn't it? Yeah. So we have various studies. We did our study here at KNH, but we didn't complete it because we didn't have enough funding. So, but I'm going to present one from Zimbabwe and South Africa. So what happened is that in European countries and Asian countries, they had already published this work that people with the poor metabolizer should not be given tamoxifen. They have to be given another drug because they will not benefit at all, okay? But now for Africans, we didn't know which direction we could go. So that is the way it is metabolized. So that is tamoxifen up there. Then it is converted to the NDM tamoxifen, and then CYP2D6 is the one that metabolizes the last portion that converts it to endoxifen. And endoxifen is the most important metabolite because that is where the activity rests. Okay, so that is CYP2D6. CYP2D6 is the enzyme that gives us the active metabolite that translates to therapeutic effect. And as I had shown you earlier, it has star 4, the European null allele, star 5, and then we have star 10 in Asians, star 17 and star 29. All these ones are all reduced or null alleles, okay? So the distribution, I'm just repeating it here so that I bring you back to speed. That star 17 is about 34% in Africans, but doesn't exist in Caucasians or Asians. So it is an African-specific allele. Luckily, it is a reduced activity allele as opposed to the star 4 in European countries where it is fully non-functional. So I've already mentioned that, the distribution in different populations, star 4 for Europeans, star 10 for Asians, and star 17 for African populations. So colleagues in Zimbabwe, they genotyped breast cancer women who are taking tamoxifen, and they were able to demonstrate that this theory that we have here, the genes, the genotypes, can actually translate to clinical application. Okay, and this so they did a study to verify tamoxifen and CYP2D6 star 17 in African populations. So this is the study they did. This is the paper they published, and this is what they found. I don't know whether it is visible on the screens. Well. So on my left or my right? Is it visible? I think it's very faint, but from where I'm sitting on my right is where you have the normal, people with the normal gene, which have no problem. So their blood, the endoxifen levels are around 40. So they are okay. They'll not be affected. Then the people who have the gene that is mixed, star 1, star 17, then they have their levels somewhere around 20. Then the last part, the ones that have double, star 17, they hardly have any endoxifen in their blood. So they will not be able to benefit from the treatment with tamoxifen. Yeah? And you see, you will not know. What we shall know is that a patient is not responding in our clinics because we do not test for these genes. As I already said, you can only know a gene exists from phenotype. So in our case, since we don't test, we shall not be able to infer. But in those countries where they have already tests, a patient must be tested before they are given the tamoxifen. This is another study they did, just better. But the publication had better figures. So you can see the normal people are there in the middle. The blue one are the normal people. Then the one on my left in green, Those are the people who have slow enzyme. So you can see their blood levels is quite low. And again, they were able to find some people with rapid metabolism. I mean, no, sorry, the people with, yes, the people with normal stroke, ultra rapid, okay? So they found that actually you can relate the levels of endoxifen directly with the genotypes. And therefore, it is very important for us to listen to this pharmacogenomic Bible story. Okay. So I wanted to continue going on and on, but I think I will stop there. So I'm just hoping that with those studies and those things that I've said, we can be able to have a keen interest, that have stimulated some interest in young people to take up pharmacogenomics by being very vigilant in the clinical sites. Because some of these things you can only, like, because pharmacogenomics, or genes, you can't see them on a patient's face. You can only infer if you see a patient who is failing therapy. So as young people, when you go to clinical sites, be keen to observe clinical outcomes and be interrogative, be inquisitive, so that you can be able to find out. That is how penicillin was discovered, okay? Sir Fleming, he just left some petri dishes in the lab. When he came back, he found some growth. Then when they characterized, they found the mold that was there was actually a penicillin. So being inquisitive is very important. Follow up the unique cases, because as you have seen, the genes, they affect few people, but very profound effect. So you can be able to tell if you actually look carefully at some of the unique cases. And actually, that is how pharmacogenomics was discovered. It was discovered way back in London when people were using a medicine called dibrisoquine. It was given to a patient who was a poor metabolizer. And this patient had very high levels. Patient was very sick, and all consultants were congregating in the hospital. So the patient actually passed away due to toxicity. And now people were trying to find where the fault was. Nurses, everything. So when they actually, somebody suggest, that is when the science of genomics was just coming up. So after they did the blood levels, somebody said, let's find out the gene. When they did the gene, patient didn't have the gene. They had the STAR5, the deleted gene. And therefore, when they took dibrisoquine, they will not metabolize it at all. Therefore, the levels were very high. From there, the science of pharmacogenomics really took off like fire. So be inquisitive, do operational research, collect cases, and you may come across some unique cases. Do networking. Thank you for attending this scientific fora. And you can join in our collaborations. If you wish, you can reach out to me and Prof. Guantai if we have any collaborations which can further your knowledge. And with that, I want to thank you very much. So we have other studies by my other colleagues, but I was not able to present them. Dr. Nyamu has done work on warfarin, Dr. Mugendi on atasanavir, another guy called Dr. Musa in Cambridge. So we have a long list of people who have worked in pharmacogenomics. So we hope that with that we'll be able to keep up bringing up more data in that area. So thank you very much.
Thank you, Professor. Please let us applause Professor more. Thank you so much, Professor. And one thing that I have picked from this presentation, there is a very big potential here for all of us, for the scholars. You have seen that so many things have not been done, okay? And again, for the business people and all of us, I hope Dr. Machogu would have been here. There is an opportunity to provide a service and make money. And I did a reference, and I found that the global market for the personalized medicine will be 1 trillion USD in the year 2034. And in Kenya, or in the low resource settings, actually nothing has been done. And when Professor was presenting, I got a little bit, I had some discomfort because I asked myself, how many people outside there are suffering because of these alleles? There are so many. Therefore, Professor, the fire, you say that, pharmacogenomic fire started, spreading, but that fire still, I can still see it, all over. Okay? Therefore, for all of us, there is an opportunity here for us as scholars and as business people. Yes. Now, without further ado, we are going to have a very interesting presentation as well from Dr. Siokao Ilovi. Dr. Ilovi, she is a consultant geneticist, a physician who is currently working at the Department of Medicine and Therapeutics, University of Nairobi. Dr. Ilovi, welcome. Okay, unfortunately, Dr. Ilovi is not online. We are going to wait for her to possibly log in. But meanwhile, we'll go back to Professor Susan. Professor, are you there?
Yeah, I am here.
Please proceed.
Okay. Yeah. Okay, well, thank you again. While we wait, I can talk a bit about limitations to the pharmacogenomic testing. So one of the problems we really have with the tests is they work the way if you go for a COVID test or an influenza test, you test and it says, yes, you have it, or no, you don't have it. So the things being tested are for those variants. We don't test for the normal one. We only test for the variants. And if it's there, it comes back and says it's positive. You have star 2 or star 3 or whatever, like Dr. Oluka was speaking about. But if you don't have, if what you have is not that particular one that's on that testing panel, it just shows you're normal. The problem with that is that we don't know all the alleles. We don't know, there may be a star 27 that we haven't come up with yet, that we haven't seen yet. And it may be in Kenya. There may be people in an isolated population, some places in the world, that they haven't done these tests on and they haven't found the variants yet. So we don't know if you test and it comes back normal, does it mean you really are normal? Or does it mean you really have an unknown variant, which we never have figured out yet? So it's important to understand that it could be a false test as far as giving, it could say you're normal and really you're not normal. And that's, again, that's a very big, it's a bigger problem with people who are not of European descent, because a lot of these tests have been studied and studied and studied with the European populations, but not so much with the African populations, not so much with the Native American populations or some other groups. The other thing, as I talked a little bit before, the science is evolving very rapidly and new gene drug pairs are still being discovered. So even if you have a current test done, it may not be done on all the possible genes because they haven't developed tests for those yet. And there are some guidelines like warfarin dosing guidelines under CPIC that incorporate genetic testing or pharmacogenomic testing, but the test is not commercially available. And that's another business opportunity for people to develop some of these tests that should be done, but they're just not out there yet. So another problem is because they're expensive, only wealthy people can afford to do it. And in the US, some people have insurance that'll cover, but most insurances don't always. Sometimes some place may have government health care that may or may not pay for it. And they may only pay for a test for a specific condition. So it may be that if you go, like on my hospital example, the person had a heart attack. So for the heart attack patients, they pay for these tests, but they don't pay for all the tests. So if this person later develops depression or something, there may be other tests that they should have had to help figure out which medication they maybe shouldn't take, and maybe they didn't get those. Also, even though they may have tests available, there may not be available for any price. In some areas, you may not even be able to get them. In the US, sometimes patients are able to order these online, but a lot of times you have to have a prescription from a provider, from a prescriber. And so if you don't have a doctor who's interested in giving you and allowing you to take the test, you can't order it yourself. Now, some places that's different. Some places people are able to order it, and some places they're not. It depends on the rules where you are. But another thing is there are some bad actors out there that are not really going to give information. They're offering online testing, but they may only be trying to steal someone's information. So we also have to watch out for those and always go with a reputable company. And we have some ethical things to talk about, and this could be more discussion sort of thing if it's possible, or I can bring them up and maybe people can talk about it later. But one problem, this would be an example of a test or not to test example, because it goes between the principle of beneficence or wanting to do good versus the principle of autonomy for the patient, that they have control over their own health care. So the medical provider wants to provide good care and recommends testing in order to eliminate treatment choices that would be likely to cause harm or medications not likely to be effective and guide future therapy. The patient may not want to test because they maybe don't want to spend the money. They may not want to wait until the answers come back, or they may not think it's that helpful because it doesn't say this thing will really work. It just says that thing won't work. So that's one kind of back and forth ethical dilemma to talk about. Another one goes back to the test results. A lot of them are based on those normal results from people who are European or maybe even Asian ancestry. If a patient is African, maybe if a patient has lived in a remote area, whether in Africa or somewhere else, but they haven't mixed with Europeans and Asian populations, is it worth doing the test to see if the patient is at risk for the ones that we know about? Or is it more dangerous because they're likely to be called normal, even though they're not normal? And so they have a false sense of security and they may actually have a problem. So that is another interesting question. Another interesting question is one of unexpected consequences. So we talk about non-maleficence or not doing bad. One of the things, the way they do these tests is generally in testing panels. They have a number of genes that they test for. You maybe have the cardiac panel with these genes, or the psych panel with those genes, or the overall. Some people will do the whole panel, which does everything that they know right now. But if you're going in and you have, say you're doing the psych panel for this particular drug, as you saw we got a list of various ones. Sometimes you learn results of something that have implications beyond the reason you were doing the test to begin with. For example, MTHFR is a protein that uses folic acid to metabolize homocysteine in the blood. This is generally included in the psych panel because if there are alterations to this gene, it increases the risk of depression in people. And this could be something that if you're looking at a psych panel, you might be interested in knowing. Another thing it does, though, if you have these alterations, it can increase the risk of blood clots, heart diseases, and stroke. And if you have too much homocysteine, it has also been linked to neural tube defects in babies. So if you're a patient and you're going to find out about whether or not you should take this medication, but you also find out this other bit of information, now are you stressed because you think now I'm going to have a stroke because I have this problem? And so now you get really anxious. And so maybe you do, or where you might not have otherwise, you might not have known about it, might not worry about it. Or maybe someone might decide not to have a child because they're afraid of neural tube defects, even though you can take folic acid and probably prevent those. So you can have life decisions that you make based on these results that could actually be harmful for patients. This is another interesting question. So say you get your pharmacogenomic testing done and you find that you are positive for this gene that makes it more likely that you're going to have life-threatening hypersensitivity to these medications. So non-maleficence, doing no harm, your healthcare provider wants to tell everybody in your family, hey, you could have this gene, you could have this problem. But maybe the patient doesn't want that to be done. And it could be, maybe they don't want the family to know they have HIV. Maybe the patient knows that the one they think is the father isn't really their father, and they don't want to have that family problem going on and cause these problems because they find out that they have this gene and other things happen. Or the family members may be opposed to genetic testing and angry that the person did it. Some people are very opposed to getting these tests done at all for various reasons, and so that could cause family drama or problems. So those are some other possible unexpected consequences that could happen. Another thing I did want to talk about just a minute was future trends and business opportunities. Now, this is kind of coming from the American side to Africa, but I would think that the same things might be available for you all in Africa. You might have to go back a few steps, start at the beginning and build the businesses. But in hospital pharmacy, you can certainly incorporate certain tests, especially prior to starting chemotherapy, to optimize dosing and minimize side effects. I think it would be great if we could test people at birth, but of course that's not financially feasible here or there right now. But a goal might be to do that so that we have that information moving forward. Or we can test to see why medication or multiple medications are not working. And when I was a director of pharmacy at a small community hospital here, I worked with the director of lab, and we brought in pharmacogenomic testing there. Now, we didn't do it a lot in the hospital because we had to send it out to get the results, and it would take a couple weeks at that time to come back. That was about 10 years ago. And we didn't keep patients in the hospital for 2 weeks. But for outpatients, it was very effective because they could get the testing done and then they could get the information and then they could talk to their doctor about it. But retail pharmacies here are starting sometimes to cover it. And again, what they do is they partner with a reputable testing company and then they provide the testing to the patients. They talk to the patient about the test, what it costs, what you will find out, what you won't find out, help the patient get the sample, send it off to the testing company, and then they get the test results. And then the patient will pay the pharmacist to consult with them and explain the results. And they'll put the results in the medical record. They may contact the physician to change some things that might need to be changed. And so that consulting type thing is a moneymaker for some retail pharmacists here. There's also a person who graduated from the University of Kansas a couple of years ago who went on and got a master's degree in pharmacogenomics, and he works as a consultant to physicians. So he isn't working with a pharmacist, but he's working with the physicians. And what he does is basically he talks to them about the test results, explains the thing, how it works, what does it mean, and he will work as a consultant to the medical providers or to the pharmacists in the pharmacy. Maybe it's somebody like myself, they graduated a while back, they didn't have this information, and so he'll come in and he'll counsel the patients for them, or he'll help them set up their software and things like that. So a consulting business is a good thing because he doesn't have money out for product. He just gets paid, for doing his consulting. And so it's been a good business model. And another one, like Dr. Oluka was talking about, was looking for new gene drug pairs, looking for unknown variants, helping develop drugs that are more effective for these people that do have the variants, looking at local variants like has been done at the University of Nairobi. All of these things are very, very helpful. And also you could even with the BS in pharmacy, you have had so much science. You have the knowledge and the background to develop these tests. And there are so many tests that are not there that could be made possible. And depending on how it's made and what it costs and so on, it's possible that over time these could become less and less expensive. As we've seen the costs start to come down, it used to be a couple of $1,000 US to get some of these done, and now they're more like $300 or $400 US, which is still a lot of money. But if we can get it down to maybe a more inexpensive product that could be produced less expensively, could maybe provide quicker answers, so you could turn it around quicker for a hospital pharmacy or something like that. All of these are areas where we need people to go and do that. And you all are very well situated to work on those things as well. So that's what I have for the moment. I don't know if there are questions or people want to have a discussion.
Okay, thank you so much, Professor King. And before we can go to that session, question and answers, Professor Bantai, do you have something to add to the presentation or a comment? Mm-hmm. Mm-hmm.
Very, very. So I think let me not try to dilute the impact that she has already made. Okay, I'm okay.
Okay. Yeah, thank you so much, Professor Gwantai.
But again, for the University of Nairobi, I think we are not used to shouting too much on our achievements, so people don't know what we've done. Like I don't know whether many people knew we were actually very strong in that area of pharmacogenomics and pharmacogenetics. But again, the discussions here open an avenue for collaboration with the University of Nairobi. Okay, there is capacity, there is competence there, and we can build a value in society. So let's spread our wings, take advantage of the human resource that we have, highly trained, and let's have an impact in society. Thank you.
Thank you so much, Professor. Dr. Sagwa, we are going to have about 10 minutes of Q&A. And this time the mic is with Dr. Sagwa. Dr. Sagwa, karibu.
Oh, thank you so much, Dr. And thank you for all the presenters. This was really enlightening. My name is Dr. Sagwa, pharmacoepidemiologist. And I wanted to look in the therapeutic area of anesthesia. And let's start from local anesthesia. So what we are getting from reports in practice is variable responses of some local anesthetic, and a case in point is bupivacaine. And we are not really understanding what is happening, because when you check the quality of bupivacaine, the samples and the batches that are being brought, it passes compendial pharmacopoeia testing. So the question is, what could be happening? And that field of anesthesia is a field that you wouldn't want to joke with. You can imagine if you are in pain and you are getting bupivacaine, and you're not going to benefit from it. I think it's something that is worrying. And related to that is the issue of in general anesthesia, although I don't know the prevalence, but I do recall when I was in school, we were being told about malignant hyperthermia. So when I had this, it just made me to remember, because those days when we were in school, malignant hyperthermia, maybe it's me who didn't understand it, but it looked like it's just something bizarre that happens. So when you're having a patient being prepared for anesthesia, and then the patient experiences malignant hyperthermia, is it a phenotypic manifestation of an underlying genotypic issue? So that is in the field of anesthesia. And lastly, these examples are what I would call, small molecules. We've seen also issues with the oxytocin, which I'll call maybe it's a peptide. And I'm not so sure whether the variance in patient response to oxytocin could also be explained through pharmacogenomics, because we test those samples in the lab and they pass the compendial testing. So the question is, what could be happening to the patients? Maybe what is it about the patients that are making them not to respond to those medications? So those are my two questions.
Thank you so much, Dr. Sagwa. And since we have a very short time, we are going to remit, the questions that will be directed to Professor King. But Professor, I will ask one question, being the chair of the session. And the issue is on population pharmacodynamics. When drugs are being registered, after clinical trials, I'm a reviewer with Pharmacy and Poison Board, and I have not seen a lot of emphasis on the issue of pharmacogenomics. And my opinion is that possibly companies, when they are presenting, their data, there should be a requirement that possibly, these studies be done in various populations. It could be an opportunity, that we can be able to take advantage of and save a lot of lives if we can emphasize the need for doing population pharmacodynamics, pharmacogenomics, and we could be able, with what Professor Oluka presented, we saw such a big difference with some enzymes. And possibly it could be a chance if we can insist that the population pharmacogenomic be a requirement for drug registrations, or be part of clinical trials? Professor, please, you have these three questions. You can attempt to answer them and then we can proceed. Thank you.
Okay, well, so the question on if there is a pharmacogenomic reason on the malignant hypertension is it's possible that there is. There are a couple of genes that are involved. So it is possible. It's not ones that we have spoken about today, but there are some that are involved, and there's more science coming on that one. There's a lot of there's some science that's been done, and probably more to be done, I guess. And I'm sorry, I was considering that one and not thinking about the other question. So what was the other question specifically?
Bupivacaine. There is, we have observed some patients, they don't respond to bupivacaine. Therefore, there could be a possibility of the enzymes polymorphisms as well.
I would say the same. I would say the same. I would say for sure it would be something that that could be an issue.
There's the other question of population of pharmacogenomics, the need for population pharmacogenomics for, as a requirement for clinical trials, because there is an opinion that if we can do a population of pharmacogenomics in, let's say, Africans, population, Caucasians, and at that time, we can be able to pick very key effect of polymorphisms. Professor, up to you.
Oh, absolutely, absolutely. And going back on the bupivacaine, that one is metabolized by the CYP3A4 that we talked about, so that if you had a lower activity, it would make higher drug levels, or a lesser activity, it would make lower drug levels on that one. So it definitely is one. But going back to the research and the development, absolutely, it's so important to have a broad sample of people, because that way about all these different variations, and you see these different types of metabolisms. You can maybe, when you're developing your drug, you can make your design such that maybe it's not metabolized by this one, maybe it's not metabolized by that one, and so it's more effective for everybody. Or maybe you make it so it is, depending on which way you want it to go. But absolutely, it's so important to have all of those, to have everyone included in the research and the development, and to keep doing that. It's so very important. There's so much has been learned, but there's so much left to learn in this field. It's a very exciting field, because it's always changing. There's always something new being discovered. So.
Okay, thank you so much, Professor. And one thing that I can tell you, we have a lot of questions, and I will ask our team, to go back, and they go to the link and they ask those questions, and then, Professor, you can be able to handle them later. Otherwise, Professor, we are going to clap for you in a, and I hope the team, let's clap for Professor King. She has given us a lot of enlightenment, and let's stand up and clap for Professor. And those online, please appreciate. Okay, let's clap.
Thank you so much. Thank you so much.
Thank you so much, Professor. We have really appreciated your presentation. Thank you.
Leadership in pharmacy, we have had strong collaboration in enhancing skills in vaccinology, and we have trained very, very many pharmacists to administer vaccines. You remember what Dr. Sam Edita said in the morning? They are running a vaccination center. And now we have over 300 pharmacists that have been trained, and we are expanding that scope due to that strong collaboration. Thanks, Susan. I look forward to having a stronger partnership with you. And say hi to Pat. We shall see him tomorrow.
Great. Thank you. Thank you, Professor. Thank you, Professor King. Yes, I'm told Dr. Siokao Ilovi, she's here at last. Dr. Ilovi, welcome to present to us. And allow me to introduce you just a little bit more, that Professor Siokao. She's a consultant geneticist, and she works at the Department of Clinical Medicine and Therapeutics of University of Nairobi. Professor Ilovi, welcome to make your presentation. Welcome, Professor. Thank you.
Thank you very much. My name is Dr. Ilovi from Department of Clinical Medicine. I'm a clinical geneticist. My apologies, I could not join you in person. Could you please have this? Yes, thank you. Maybe next slide, please. I hope I'm audible. So maybe we can skip this slide in the interest of time. Okay, so from the clinic, I was asked to come in and give some of the perspectives of the pharmacogenetic studies that we are carrying out and what's led to them. So maybe we can go to the next slide. I think this has been covered by the previous presenters. Because now we're in our precision medicine. We can just go to the next slide in the interest of time so that I share the slides that we have done, the studies that we have done. So then we ask ourselves, like the previous presenters said, pharmacogenetic studies regions are lacking. Could we begin to answer some of these questions? So our first pharmacogenetics looked at the phenotypic expression. We went and looked at renal transplant patients who have who are on tacrolimus and routinely have their serum tacrolimus staph levels measured periodically. And using the dose to concentration ratio, we are able to map out their degrees of metabolism. We had about 95 post-transplant patients, and we were able to show about a third. What? They demarcated into fast metabolizers, intermediate metabolizers, and slow metabolizers, as is shown in those two slides. The next slide, please. And most interesting is that this metabolism had an outcome on the allograft survival, so that the patients who are slow metabolizers, the one in gray, had better allograft survival because they would have more tacrolimus in their system. But that also contrasts with the risk of adverse events of tacrolimus. And similarly, the rapid and intermediate had poorer allograft survivals because they mop out more of the tacrolimus from their system. So then we ask ourselves, this is the phenotypic expression. Next slide, please. Then now we've gone back and said we have seen the phenotypic expression. We have patients who are slow metabolizers, intermediate, and fast. Can we go in and look at the genotype that predicts this phenotypic expression? So right now we're undertaking a pilot study. Look where we are prospectively recruiting patients who are on tacrolimus post-transplant. And then we are going to see whether the first will be able to map up the CYP3A5 and CYP3A4 and see whether that correlates to the genotypic expression that we are seeing. The next slide, please. And these are some of the genes that we will be looking at. Like somebody, I think the previous presenter was talking about bupivacaine. and it being metabolized by CYP3A4, which is one of the two genes that are associated with tacrolimus metabolism. So it will be an interesting study to help us understand what are the genotypic profiles of our patients. Next slide, please. Sorry, please go to the previous slide. We are going to look at 46 genes, and I've just mapped out specific ones with drugs that are of clinical interest to us, particularly in the post-transplant patients. Quite a number of them are clopidogrel. Clopidogrel being a prodrug, some patients may not be metabolizing it optimally. NAT2 gene, which are patients take isoniazid post-transplant. So it should be good to see whether they are optimized for the isoniazid. And then virtually all of them are on cotrimoxazole for the first 1 year. So it would be good to see what their glucose 6-phosphate dehydrogenase is, particularly for the men, because that one is located on the X chromosome. So we believe this study will help us begin to define and describe amongst our population. So that is the current study that we are going. The next slide, which I just want to highlight that for us in the clinical setting, sometimes drugs interact with genes that are not in the traditional described pharmacogenes. And I'll just use one clinical example where we had a 15-year-old female who presented in sudden cardiac arrest and had been put on sumatriptan 3 days prior. Notably, after post-resuscitation, she was found to have QT prolongation, which is a side effect of the drug. But of note is that she had multiple first-degree relatives who'd had prolonged QT. So even as we are beginning to map out genes, we are extending beyond pharmacogenes just to understand how genes interact with drugs and can cause severe adverse events like we had in this patient. Next slide. I think that is the last. That's the last slide. Thank you very much.
Thank you so much, Dr. Ilovi, for a very clear and brief presentation. Do we have any question for Dr. Ilovi or to Dr. Ilovi? Any question? Professor Gwantai?
Yeah, my quick question is, we are pharmacists and also as clinicians, we keep on talking about the need to identify and report adverse drug reactions and side effects, but thereafter we don't ask ourselves, how do we help the patient? Apart from identifying and reporting, what else? So as I think that we need to move to the next step of trying to assist the patient. So Dr. Ilovi, what would you propose to do, particularly considering that in Kenya, we do not even have insurance companies that can cover the patients that would need to go for such tests? How do we advise the patient? What do we do? The way forward for the patient.
Thank you very much, Professor Gwantai, for that question. You've raised very pertinent issues regarding insurance discrimination. I think on that front, what we need is a critical mass that begins to lobby for these investigations, which I think with enough lobbying will become mainstream and will have a voice to speak. In regards to documenting our findings, I think once we have them, and with the school pharmacy, we'll be able to start describing and mapping out how to best capitalize on optimizing treatment for patients using genetic information.
Thank you so much, Dr. Ilovi. And I am also of the opinion that we should have a strategic document that will highlight that this is actually, a problem. I don't think, and possibly Dr. Ilovi, you can tell us whether we have any document to show the missed opportunities, for the lack of, any plan or strategy to introduce this individualized medicine in our clinical setup. This is just a follow-up, questions to what Professor Gwantai asked. Do you have any strategy, you see, as a country, because we need to have, a kind of position paper or even a document that we can use to lobby. I don't know whether there is anything that you know. And also, Professor Oluka, still, the question will apply. You can help answer that question.
Thank you very much. I think to the best of my knowledge, there is no document, right? And I think these discussions make very fertile ground to begin to formulate some of those strategic plans.
Thank you, Dr. Ilovi. Professor Oluka, do you have any plan to use? You see, this country, it depends on us, on you. You are the experts. Do you have anything that, any document that highlight that there is a problem, even to our policymakers?
Thank you, Dr. Kimoto. As of now, I do not think there's a document, but I know that there was a group of people meeting under the Precision Medicine Africa, and they sponsored, the meeting was being conducted through the NRF officers. So that seemed to me like a meeting that was well organized. The funding was actually from the European Union, African countries, to put their cases together and come up with how to practice precision medicine. When I went to that meeting, I also met people from here. Prof. Jaoko was there, and also Prof. Anzala. So we could probably follow up with NRF if there was any. I did not stay long enough to see whether there was something to follow up after that meeting.
Thank you. We are going to leave that one with you, our experts, and possibly you can provide, a clearer direction on the matter. Okay. Any other question for Dr. Ilovi before we can close the session? There's one question there.
Okay. Okay, so good evening, everybody. So thank you, first of all, to all the presenters for the session. So mine is just a quick question. If someone, let me say a current student or someone who's just finished school is interested in maybe learning more about pharmacogenomics, maybe what will be the best way to approach that? Like, what's the best starting point for that? Yeah.
Yes, thank you so much. That's quite a good question, and I will toss it back to Dr. Ilovi and Professor Oluka. Dr. Ilovi?
Okay, perhaps I can answer that question from the clinical perspective. I think the best way first would be to identify a certain drug and then try and map out the specific genetic polymorphisms that are attributed to that drug from a clinical perspective.
Yes. Thank you so much, Dr. Ilovi. Your answer is well received. And Professor Oluka?
Thank you, Mr. Gitao, for that question. In the School of Pharmacy, we have a program. It's called Molecular Pharmacology. And some of the studies that you saw me presenting actually come from our master students of molecular pharmacology. So after you have done your internship and you have practiced, well, I don't know how long you want to practice, but you'll be welcome to come and join the Masters of Pharmacy. No, it is actually a Master of Science in Molecular Pharmacology. And you will learn about pharmacogenomics at that level, and then you can proceed to do your PhD. I can link you up with Dr. Kagia, who was here yesterday. He's now in Kabarak University, having gone through our program, and he can mentor you there some more. So that is what I can say to all our students. We have the MSc program, which will give you the introduction to pharmacogenomics, and then you can see how if you want to specialize in it or not. Thank you.
Thank you. Professor Guantai?
That for those people that want to be even more specialized in that area, we have a PhD program, in pharmacology and therapeutics, okay, that allows you to specialize in specific areas in the area of pharmacology and therapy. And one of those areas is pharmacogenetics at PhD level.
Great. To our students, you have heard about these opportunities. They are for you. Thank you so much. Do we have any question from our online audience?
Also to add that in our program, we have a very close collaboration with Dr. Kimotho's lab. So he should not stand there and say that, oh, ask Dr. Oluka. Because his lab is one of the labs where we take students for practicals. He has a good equipment and good exposure. So Dr. Kimotho is one of our, actually he's one of the faculty for pharmacogenomics.
Yes, thank you so much. I'll just say that in Kemri, we have also a team led by one Iba Aluvala, which is doing some work on population genomic. And also with the introduction of Messenger RNA Center, we'll be able to kind of also provide solutions, some of these solutions. Yeah, therefore there is hope, but I think we need to come together and we bring, our diverse expertise that is there, and we provide a kind of a policy directions in this country. Thank you. Thank you. Any audience online who would like to air an opinion or a question to the panelist, to the presenter, sorry? Do we have any chat question? Yes, it appears we don't have any question from our online audience. And I can see for those of us who are here, let me tell you, they have been very alert audience here. I didn't see anybody dozing, and it is quite unusual at such a time like this to have the attention of all of us. And to me, it has been quite educative, and I have appreciated the audience. You have been very, very, very participatory. Thank you so much. With that, let us clap for our afternoon presenters. They were good presenters. We appreciate you, our presenter.